The third interesting topic is on 2021 guidelines for coronary artery revascularization from American College of Cardiology and American Heart Association. The top 10 take-home messages are as follows. The first message is that the treatment decision regarding coronary revascularization in patients with coronary artery disease should be based on clinical indications regardless of sex, race, or ethnicity. The second take-home message is that in patients being considered for coronary revascularization for whom the optimal treatment strategy is unclear, a multidisciplinary heart team approach is recommended. The third take-home message was that for patients with significant left main disease, surgical revascularization is indicated to improve the survival relative to that likely to be achieved with medical therapy. The fourth take-home message was that the updated evidence from contemporary trials supplement older evidence with regard to mortality benefit of revascularization in patients with stable ischemic heart disease, normal left ventricular ejection fraction, and triple vessel coronary artery disease. The fifth take-home message was that the use of radial artery as surgical revascularization conduit is preferred versus the use of saphenous vein conduit to bypass the second most important target vessel with significant stenosis after the left anterior descending coronary artery. The benefits were seen as superior patency, reduced adverse cardiac events, and improved survival. The sixth take-home message was radial artery access is recommended in patients undergoing percutaneous intervention who have acute coronary syndrome or stable ischemic heart disease to reduce the bleeding and vascular complications compared with femoral approach. The seventh take-home message was that a short duration of dual antiplatelet therapy after percutaneous revascularization in patients with stable ischemic heart disease is reasonable to reduce the risk of bleeding events. The eighth take-home message was that the staged percutaneous intervention of significantly stenosed non-culprit artery in patients presenting with ST segment elevation is recommended in select patients to improve the outcomes. Percutaneous intervention of non-culprit artery at the time of primary percutaneous coronary intervention is less clear and may be considered in stable patients with uncomplicated revascularization of culprit artery or low complexity non-culprit artery disease and normal renal function. In contrast, percutaneous intervention of non-culprit artery can be harmful in patients in cardiogenic shock. The ninth take-home message was that revascularization decisions in patients with diabetes and multivessel coronary artery disease are optimized by the use of a heart team approach. Patients with diabetes who have triple vessel disease should undergo surgical revascularization. Percutaneous coronary intervention may be considered if they are poor candidates for surgery. The 10th and last take-home message was that treatment decisions for patients undergoing surgical revascularization of coronary artery should include calculations of patient's surgical risk with Society of Thoracic Surgeons score. Thank you.